Hi class, Dr. Jim here. Unit 5. So we're up to the units that are looking at organisms that cause disease. So in the next few chapters, we're going to be looking specifically at bacteria. So we'll be looking at the gram-positive and negative coxy today. In chapter 19, we're going to be looking at the gram-positive bacilli that cause disease, the gram-negative bacilli or chapter 20, and then the spiral and irregularly shaped bacteria are in chapter 21. Then into Unit 6, we'll get into the fungi, the protists, DNA viruses, and RNA viruses to kind of conclude up the final 8 chapters that we have. So the next couple units, we're going to be looking at things that cause disease and what can kill us, potentially kill us. And I know everyone's excited about that. So what my goals are in here is more for you guys to get some general understanding of some of the different bacteria, especially in this, obviously in these next couple of chapters, looking at the gram-positive versus gram-negative. Just some general characteristics. I don't expect you to know everything about everything in these bacteria, but some just general information. And again, I'll point it out, especially at the end in the summary, what I really want you to know, and talk a little bit about the differences between some of these guys that we're going to be looking at today. Okay, so we're going to be focusing on chapter 18, and chapter 18 is looking at the coxy bacteria or the round bacteria. And the three groups that we're going to be looking at today is the first one we're going to look at what is Staphylococcus. Staphylococcus is a gram-positive coxy. Okay, and so we're going to look at some of the characteristics and then what diseases are caused by it. So we'll look at them. With Staphylococcus, a lot of times you can refer to the skin diseases as those. There are some systemic diseases, but the main diseases that we're going to be looking at are going to be ones that are found in the skin. The next group we'll look at is the Streptococcus. Now, the Streptococcus are a gram-positive bacteria found in chains, so the coxy found in chains. And again, there are some characteristics, and the diseases that we associate with these are typically more deeper tissues, but a lot of times you can think of things with the throat or in the chest or the lungs, sometimes getting to the heart, and then leading to some other complications that are around there. And sometimes we'll even talk about the kidneys with those guys. The last group, which is interesting, is the Neisseria. The Neisseria really have two pathogens that we're worried about. One of them is an STD called Neisseria gonorrhoeae, and the other one is Neisseria meningitis, which causes about 70 to 80% of all the meningitis, that bacterial meningitis that's out there. And so these are pretty nasty guys, thinking of just the amount of infections that they can cause. Okay. The difference between Neisseria and the other two is this is a gram negative, so it would stain a red or a pink color on the gram stain. So that's what we see with Neisseria, and so we'll be looking at that as well. Okay, so these are some of the diseases that we'll talk about, some of the different things that we'll see. I have some wonderful pictures for you guys to see today and that stuff, so hopefully you'll make it through all this and have some fun with it. And so we're on our way. All right, so how do I set up my lectures? So in the next 8 chapters are pretty much set up the same way. First, we'll identify the organism, and then we'll talk about the characteristics of that organism, being gram-positive, bacteria, gram-negative, what are their shapes, what do they produce. We'll look at their virulence factors. Now, virulence factors are things that they produce that make us sick. So that's what you're going to be looking at. So what does it cause to make the disease? Okay. We'll talk about the epidemiology and pathology. So focusing on numbers, who's at risk, why are they at risk, types of things. What does the disease do to you once it gets inside of you, or what does the infection do, type of thing. Where does it infect? We'll talk about some of the diseases that it causes, and some of them can cause a number of different types of diseases, so that's important as well. And then we'll look at treatment and prevention. So obviously when we're talking about bacteria, what types of antibiotics are effective, which ones aren't, and then what is a good way to prevent these things. So, a lot of times we can say, like with Staph aureus infections, a great prevention is good hygiene. Just having good hygiene is a good prevention. Some of these other ones, like obviously, like Neisseria gonorrhea, a good prevention would be to have safe sex, not to have, unprotected sex where this disease can spread. And so we can see some of these things, and obviously prevention is always a big thing. And so this is how a lot of these are set up. We start with the organism, work our way through, and then finish up with treatment and prevention and how to keep from getting these things in the first place. Okay, so what we're going to start with is Staphylococcus, and these are the general characteristics. Now, again, I said it was a gram-positive, okay, so it's going to be purple on the slide, and it's going to look like clusters of grapes. And so that's where the staphylo part comes from. That means clusters, and it's grape-like in appearance. And you can see under an electron microscope, it looks like grapes hanging from the vine. And they're spherical cells arranged in clusters. Gram-positive, they lack spores or flagella, so they're non-motile. And some do have capsules, but not all. And there are about 31 different species of staph that we are concerned with, or that either live on us or other animals and that stuff. But typically, there's only a few that we really worry about that cause infections. One we're going to be spending some time with today is Staphylococcus aureus, but there are a couple other ones that we do worry about that can cause infections as well. Okay, so Staphylococcus aureus grows in large, round, opaque colonies. And again, we saw this in the lab because one of the things that we noticed when we grew it on a blood plate is that it could clear the blood, and we call that beta hemolysis. That beta hemolysis is a complete clearing of the blood. It grows very well at 37 degrees. That's our body temperature. And again, we have lots of staph that grows on us. It's a facultative anaerobe, meaning that it can grow with oxygen or without. And one of the interesting things about staph is that it can survive a lot of extremes. It can survive high salt extremes, pH, and high temperatures. So if you take this from one environment to the other, it really doesn't care too much because it can tolerate a lot of different environments. So staph, where do you see it? On your skin. Your skin is a very salty, acidic place, and your staph can thrive growing on that skin. And so that's one of the things. The other interesting thing about staph in itself is that it produces a lot of virulence factors that can get you really sick if it gets into the wrong spots. So outside of us, not a problem. Once it gets inside of us in wounds and other types of infections, that's where it can cause problems. Okay, so this is a list of just enzymes that it produces. So we're going to actually have about 3 pages of virulence factors. And again, I'm not expecting you to memorize all these things, but I just want you to be aware of all the wonderful things that Staph aureus can produce that can make you really sick. The first one is called coagulase, and what that does is it coagulates blood plasma, and so it forms blood clots. Okay, now this is a definitive marker of Staph aureus. So we know Staph aureus from the other staphs because only Staph aureus clogs the blood or clots the blood. Okay, other staphs do not, and so that's a definitive test that we can run to prove that this is Staph aureus and not Staph epidermidis per se, or some of these other ones that are out there. Okay, so that's one of them, coagulase. Another one is hyaluronidase, meaning it can break down tissue. So this is the gelatinase test. I don't know if we'll be running in the lab this semester, but it is one of those tests that you can see. Staphylokinase can digest blood clots. DNase, which can break down DNA. Lipases, which can break down oils, enhance colonization on the skin. And it also has enzymes that break down antibiotics. So this is another one that can just destroy things. So staph is not a fun bacteria. It releases lots of enzymes that can just do a lot of damage to your surrounding tissues. So that's why it's a pretty nasty bug to get inside of you in there. Okay. Another thing that it does is it produces lots of toxins. So one of those things is the hemolysins, and we saw the evidence of that on the blood agar plate. So when you struck out Staph aureus, what did you see? A clearing of the blood. And that clearing of the blood means that it can destroy red blood cells. It also can destroy white blood cells through the use of the leukocidin. The leukocidin goes in and kills white blood cells. The enterotoxin that it produces can be released and cause gastrointestinal distress. So this is one of the forms of food poisoning that you might get. It also can release an exfoliative toxin, which separates the epidermis from the dermis, and I'll show you some pictures of that, where again, kind of looks like a really bad sunburn. If you remember, if you've ever had a sunburn, you may have seen where your skin gets peeled back and you have those peelings of the layers, like the epidermis peels back and you get the dermis. Well, that's what happens with the scald skin syndrome or the exfoliative toxin, is that it basically peels the epidermis away from the dermis, and I'll show you examples of that. The last one is the toxic shock syndrome toxin, and again, we've talked a lot about this already in chapter 15. This is the toxin that is produced by Staph aureus that binds to the T cells indiscriminately. So it doesn't just bind to one T cell, but it binds to hundreds of T cells, which leads to an overwhelming response to the immune system, which can then cause the tissue system to go into shock, organ failure, and eventually death in those people. And so it can cause a lot of problems. And so again, where do we see that associated with the women, menstruating women with the super absorbent tampons? And that's why the warning is on there about toxic shock syndrome. And we'll talk a little bit more about that as we go on later today. Now, some other things that Staph aureus can do, or again, getting into the pathology and epidemiology, again, it's a nasty bug once it gets under the skin. And so again, it's found in most environments frequented by humans. And again, it's found on the skin So anywhere we have dust or human contact, we're going to leave staph behind. It's readily isolated from fomites, and you guys saw that when we did our first lab of the year, when we did looking for organisms that grow over there. A lot of it was staph because we touch things and that's found in our skin. Okay, carriage rates for healthy adults for Staph aureus is anywhere from 20 to 60%. And with the MRSA, which I'll be talking about here, that's about anywhere from 5 to 10 to 15% of people actually carrying MRSA on their skin. Okay, carriage is mostly in the nose or the back of the nose, the skin, the nasopharynx, the back of the throat, and the intestine. So people have sometimes in their intestine. And again, where do we see this most of the time? Where do we see the infections? Typically with poor hygiene, because it's again associated with skin infections. Nutrition can play a role because again, vitamin deficiency can play a role with the skin. Tissue injury, where you have lots of wounds and other injury that goes on. Primary infections that happen, diabetes, and immunodeficiency. So these are all playing roles in where we see Staph aureus infections. And again, where are we seeing more of this? In these ones that are resistant to a lot of different things. And we call this MRSA, methicillin resistant Staph aureus, because it's resistant to methicillin, but it's also resistant to a lot of other antibiotics. And I'll explain why that is here in just a little while. Okay, so that's some of the epidemiology and pathogenesis associated with it. Now, what are some of the diseases that are caused by Staph aureus? Well, a lot of times these are associated with the skin and skin diseases, and so we'll talk a little bit about that. One of the diseases is a very common one that a lot of people will get, and these are these superficial little bumps that they get on this skin or hair follicle, and it's some of the acne that you get that is caused by these Staph aureus. And again, typically it's resolved, no complications. You get over it, you fight the infection, you clean the skin, and it goes away. However, if you leave it untreated and you don't clean the system or you don't clean the skin very well, it can lead to further complications. Now, one of those complications is called a furnicle, which is also known as a boil. This is a much larger pimple or sore, and again, it can be inflammation of a hair follicle or sebaceous gland that progresses into a very large wound in this case. And so typically it's a large eruption that occurs in the skin, and again can open up and ooze out or lead to an abscess or a pustule, which then can ooze out and spread to other parts. And so again, when you're talking about something this size, this isn't the time that you want to go get medical attention, when you want to seek out the doctor or the nurse to help drain that thing. You don't want to be doing that at home, because that can lead to other infections, leading to again that infectious fluid getting to other spots and leading to other infections. Now, sometimes these boils can actually grow together into a very large boil. So this would be a very large eruption of the skin, and this is known as a carbuncle. So this is a very large boil in this case, or a deeper lesion that is caused by this, where again, seeking medical attention at this point in time is really necessary, because you don't want to be handling it on your own. It can be highly infectious, can be spread from one person to the other. It also can cause problems. It can be eating away at the tissue and cause severe tissue damage as well. So that's one of those things. Now, another thing that a lot of you guys may have experienced if you've ever had kids is that you may have seen your babies when they first came out of, delivery and that stuff, and a few weeks after, is you might see what they call baby acne. And this is also known as impetigo. And it's these little bubble-like swellings. It looks like little acne that the babies get sometimes, and this is actually due to colonization of Staph aureus on the skin. So sometimes as the baby is first delivered, remember there's no colonization yet. As soon as you pass through the vagina, that's when you get first colonized, and babies will sometimes pick up Staph aureus from mom or dad holding the baby and that stuff. And what they'll get is this baby acne actually that develops from these swellings, that's due to the Staph aureus actually growing on the skin. So a lot of times this breaks and peels away, and then it goes away. And again, it's very common in newborns, and a lot of times it's referred to as the baby acne in this case. So you may have seen this before, not knowing what it was really what it was, but it's just Staph aureus colonizing onto the skin. Okay, and again, here's some examples. This is showing you again what happens inside the skin. So again, a lot of times the hair follicle will become clogged. You'll get bacteria in there, and the bacteria will grow. The neutrophils will come in and lead to inflammation, and then again, leading to the pus formation in that, and leading to the swelling. Again, what are the signs of inflammation? redness, swelling, heat, and pain. And so that's what's typically associated with this. This is typically a localized infection, nothing too severe. However, it could potentially grow into a larger infection if it's not cleaned out or cleaned up pretty well. And again, don't go popping your pimples and that stuff. It's not a good way, and it can lead to further infection and scabbing of your skin. So I don't recommend doing that as well. Okay. Now here's an example of folliculitis. So again, this is a skin infection. This looks like severe acne, and a lot of times is associated with, again, swelling of the hair follicles, and again, associated a lot of times with poor hygiene. And so you'll see this. Now this over here is actually a larger abscess. This would be a boil or a carbuncle, which is pretty large. And again, in this case, has the MRSA. And this is when you want to start seeking medical attention. This, not so much. You may go see someone about this because it's just one of those things that it's kind of embarrassing, or maybe a problem, maybe itchy or scratchy, and you don't want to be dealing with it. This obviously over here, this in the C, is something that you want to seek medical attention for, because this can lead to further infections. This can get deeper into the tissue and actually cause a lot of tissue damage around it. So this is something you want to seek medical advice for, okay? So that's one of those things that you will see. Now, staphylococcal disease can go systemic, meaning it can get into the blood and cause other problems. And one of the diseases we see is this osteomyelitis. And osteomyelitis is an infection that gets into the bones. And so what happens is the bacteria gets into the blood, and those bacteria will end up in the bones. Now, the problem that's associated with it is that it actually eats away at the bone and can lead to a weakening of the bone and leading to breaks and other things. And so you get abscess and other things that form in the bones, causing a weakening of the bones and causing premature breakage or breakage due to the weakening of the bone. Another thing you see with bacteria, or with these staph bacteria that get into the blood, is that it can lead to bacteremia, which means you have bacteria in the blood. And you knowing by all those different things that it has, those virulence factors that it has, this is not something that's good to get into your blood. So you want to make sure that you get rid of it. You don't want to be systemic. You don't want to be septic with this Staph aureus, and that's a bad thing. And so it can lead to, again, infections throughout the body, can cause tissue damage, organ damage, a lot of other things. And this can happen, again, by implementation of medical devices, sometimes through surgeries and other things, and it can lead to other complications down the road. So again, anytime you get bacteria in the blood, not a good thing, especially the staph that has a lot of factors that can affect that. Okay. Now, some other diseases through toxins that get produced. Now, one of the things is due to food intoxication. So food intoxication can be obviously where you get food poisoning causing nausea, vomiting, diarrhea associated with that. So that obviously can be a complication, and this is due to the food or heat libel toxin that it produces in the intestine. You can get the scalded or staphylococcal scalded skin syndrome, or SSS, and that again is that sunburn that you see. And so what's happening here, you can see down here that the epidermis is pulling away from the dermal layer, and so it looks like a really, really bad sunburn. And obviously this is found in a little baby. The baby doesn't understand. It's probably screaming its lungs out because it hurts so bad. It's like a really bad sunburn in these situations. So obviously not a neat thing for a baby to get. And again, a lot of times that happens when it's colonization of the Staph aureus, and then you get this on the skin, and it can cause that. Obviously, the other thing we worry about is the toxic shock. We've talked about this a number of times. Again, chapter 15, we showed the example how this gets, the Staph aureus produces the toxin. The toxin binds to the T cells, causes the T cells to respond, and then you get that inflammation, overwhelming immune response leading to tissue involvement, organ failure, and eventually shock, and could lead to death if not treated. And so that's obviously a severe situation, and this is another toxin that Staph aureus can produce. Okay. Now, there are some other Staphylococci, and again, the way that we determine some staph from others, Staph aureus from others, is by coagulase. Staph aureus, 97% of Staph aureus isolated from humans is coagulase positive, meaning it will clot plasma. The other types of staph will not. And so that's a definitive test that we can run to say, yes, you have Staph aureus, or no, you have staph, but it's a different type. And some of those other types include epidermidis, which is found on the skin and mucous membranes, can lead to endocarditis, bacteremia, or UTIs. Another one is homus, which is found in the sweat glands. You also have Captus, which is found on the scalp, face, and internal ear, which can cause skin infections. All three of them can cause skin infections if they get in. Burns, sometimes you see these types of infections, and again, typically through penetrating skin, broken skin. And then you have the Staphylococcus, which is again sometimes found in the skin, intestine, but can lead to UTIs a lot of times. So we'll see that one typically in the vagina and leading to UTIs in certain situations. But the three really that can cause other types of skin infections are here: the epidermidis, homus, and captus, which can all lead to skin infections, as well as the Staph aureus. Okay, how do we test for it? Again, we can take it from pus, tissue exudates, sputum, urine, and blood and look for the Staph aureus. Obviously, a definitive test to know that it's staph is catalase. So if it bubbles, it's typically catalase or the catalase positive for staph. Streptococcus, it's negative for catalase. And then knowing if it's Staph aureus versus other types of staph is that if it's coagulase positive, so it clots the plasma, that's typically Staph aureus. If it does not coagulate the plasma, it's some other type of staph. Okay. We also have rapid ID testing, doing some different different biochemical tests. Some of these will actually run in the lab, and we'll see some of these tests again. But this allows you to do a rapid test within the 18 to 24 hours to identify what type of staph you actually do have, and it does play a huge role in figuring out what you have and how to treat it. Okay. This is how we can identify. Again, the big thing is coagulase. Coagulase, if it clots plasma, it's typically Staph aureus. If it doesn't clot plasma, it's one of these other types of Staphylococcus species. Okay, and so I just bring this up just to show you how you can rapidly identify whether you have Staph aureus or something else causing the type of infection. Okay, now some clinical concerns and some treatment associated. Now, again, most of the staph that we treat are going to be penicillin resistant, meaning they have an enzyme that goes in and eats up the penicillin and penicillin derivatives. So penicillin, ampicillin, amoxicillin will do nothing to staph infections. So typically you're talking about stronger types of drugs that will go in and destroy the staph. Now, one of the things we worry about is MRSA, and MRSA stands for methicillin resistant Staph aureus. Why this is so nasty is that basically the cell walls on these guys are so thick that antibiotics just can't get through. And so MRSA is highly resistant to a lot of different types of antibiotics. One of the antibiotics that you can use is vancomycin, but it's not really the best antibiotic. One, it can be toxic. Two, it's hard to administer. And it's just not one of those that you really want to give. That's kind of like the drug of last resort. If nothing else works, we'll put them on vanco. And again, that can be a long-term treatment. Again, if you have abscesses or large furnicles or or carbuncles type of thing, large boils and that stuff, you want to go to the doctor to get these drained. You do not want to do it yourself because, again, you can lead to other infections, tissue damage, and other things. So you want it done properly. And again, if you get systemically, whether you're talking about the osteomyelitis or in the blood, you're going to be on long-term treatment, and it can be a lengthy therapy because depending on how aggressive the bug is and how long it stays in there and how resistant it is can play a huge role. And so that's the other thing that you have to worry about. Okay, now again, how do we prevent this in the medical field? Using universal precautions, making sure you wear gloves, prevent passing it from one patient to another. Don't be a passive carrier. Make sure you change your gloves, wash your hands, all those things. And really, and the biggest thing that what you can recommend to people that do get staph infections is cleaning wounds. Hygiene is always important. Good nutrition, things like this are all important for maintaining good normal flora so that you don't get a lot of staph infections. So the biggest thing is keeping hygiene up there. That's a good one. And again, typically when we talk about Staph aureus or Staphylococcus, where do we see infections? It's on the skin. Okay, so we're getting close to the end with staph, and then we're going to move our way to now strep. Okay, so let's do the concept check. So which test differentiates aureus from the other staphylococcal species? Is it the gram stain? Is it catalase? Is it oxidase? Or is it coagulase? You probably should have heard this when I talked about it on the test. Okay, if you said coagulase, you would be correct. That is the one that clots the plasma. And remember, Staph aureus clots, all the other species do not. And so Staph aureus, one of the definitive tests is coagulase, because it will clot with coagulase, it will clot with plasma. We'll actually run this test in the lab later on this semester, so you will see this. And so you'll see the coagulase test, and that will determine, yes, you have Staph aureus or over a different type of staph. Okay, so coagulase is the one. All right, so let's move on to Streptococcus. Now, Streptococci is again a gram-positive coxy that forms typically found in chains. So we typically see this either as long chains. Sometimes you see it as a diplococci or other types of things. Also, too, it's typically not the circle shape, but more ovoid in appearance or oval shape in those things. And again, like I said, typically found in either chains or long pairs. It's non-spore forming, it's non-motile, can form capsules and slime layers, so that's very important. Can also grow with oxygen or without, so some of these guys can grow very well without oxygen. Does not form catalase, but it has a different peroxidase system. So if you add hydrogen peroxide to these guys, they will not bubble. And so that's one of the ways to definitively test between staph and strep. Staph will bubble, strep will not. Okay. Most parasitic forms are fastidious and require enriched media. Most are very small pinpoint colonies, non-pigmented. And again, these guys tend to be very sensitive to outside environments. And so, again, changing the temperature, changing the pH, changing the saltiness will all affect strep. Staph doesn't seem to be bothered by it, but with strep, they seem to be very sensitive to any environmental changes. And so that makes a big difference between strep and staph in these situations. Okay. Here's a picture of strep. You can see again gram-positive, very purple, and in chains. Coxy shaped, round to ovoid shape, and again long chains, and that's what you see. And some of you guys saw this when you did your gram stain of your teeth. You saw these long chains of strep. And again, that doesn't mean you have strep throat, but you probably have a type of strep in your mouth, part of the Verdans group that is ones that we do see with associated with teeth and other things in the mouth. Okay, now strep can be classified based on the type of cell wall antigen it has, and we have actually 17 groups, and those groups are A, B, C, D, and so on and so forth. So we label them based on the type of antigen they have, and typically we can also base them on the type of hemolysis they do. Now, you are familiar with the beta hemolysis that we've done in the lab already with the blood agar plates, and you saw that it clears the blood all the way through, that you can look up in the plate with the light and you can see right through the plate, and that's beta hemolysis, complete clearing. Now, there are some strep that actually can do partial clearing, so they leave some behind, so it doesn't clear all the way through, and you can kind of see the difference here. You can see a very dark clearing. Here you can kind of see a partial clearing and actually even some green, and that green represents some of the heme that's left behind. So it doesn't completely clear, doesn't go all the way through the plate, and so that's what we call an alpha hemolysis, or a partial clearing. Now, most species of strep actually are beta hemolysis, and that's one of the reasons why they do a blood agar plate when they test you for strep throat. But some do only partial clearing, and this would be found in some of these other groups like Strep pneumoniae and some of the mouth bacteria. So we'll talk about that in a little while. So that's why they do the blood agar plate, to see if you have strep throat or not. And we'll talk about that here in just a few minutes, okay? So again, we can range these based on how they're sensitive to either to bacitracin or opicin or some of these other types of tests. And again, whether they clear the blood or don't clear the blood, that's another way we can test for these bacteria. All right, so here are some of the list of the different types of of the different types of strep. And again, the ones that we're going to be looking at today are the strep pyogenes. This is probably the most serious of all the pathogens. Agalactae is found a lot of times in newborns because it's carried in the mom's vagina, so it can be spread during delivery to the baby and can cause meningitis. The enterococcus tend to be found in the intestine, and so it used to be called Streptococcus, but now we call it enterococcus because it's found in the enteric system or the intestine. So that's why it's called Enterococcus faecalis. Okay, another one is the sanguis, mutans, and pneumoniae. The sanguis is found in the mouth. The mutans is also found in the mouth, and these are ones responsible for cavities in the mouth, but they also can lead to endocarditis if they get into the blood. And then the strep pneumoniae is the one that can lead to pneumonia, so the bacterial pneumonia. And we're going to talk a little bit more about that near the end of the strep part of this chapter, and we're going to look at that a little bit more closely. There is a vaccine for it. You may have seen the commercial for it about doing the one thing, taking the one shot and protecting yourself. So you see all those people doing just one thing or eating one asparagus or one strawberry type of thing. That's the shot they're talking about there. So we'll look at that as well. Again, you can see the different groups that they're found in, what type of clearing they can do, and where they're typically found. And so we'll talk about that as well. Okay, so again, here are the pathogens we're going to be concerned with: the pyogenes, the agalactae, the verdans strep, which is found in the mouth, strep pneumoniae, which is the one responsible for bacterial pneumonia, and then enterococcus faecalis, which is found in the intestine. So we'll look at that as well. Okay, so let's look at strep pyogenes. This is the most serious of all the streps. It can cause a lot of different diseases, but typically we associate it with the strep throat and other diseases around the throat and then leading to other parts of the body. So it always typically starts as a strep throat or a strep infection of the throat. And then if it's left untreated, it can go to other parts of the body and cause damage. And we'll talk about that. It's a strict parasite found only in humans. Strep pyogenes only infects humans, and it's only spread from human to human. Okay, habits the throat, the nasopharynx, and occasionally on the skin. And typically, where do we see this? Is when people cough and sneeze and pass it to one another in that way. Okay, so that's where we typically see these guys. Again, it has a number of surface antigens that can cause an immune response, including the C carbohydrates, which protects it against lysozyme. So again, doesn't get destroyed by saliva because it has this thing that protects it. The fimbriae allow it to stick. It has the M protein, and the M protein is one of those distinguishing characteristics that allow you to identify the different types of strep that are out there. Again, we saw that in that video about strep throat with the clonal selection theory, and the M protein a lot of times is what makes an immune response. Again, it also helps keep resistance to phagocytosis. Again, you have the hyaluronic capsule, which prevents no immune response, and then this protease inhibits complement and neutrophil response. So you can see these guys prevent the second line of defense from attacking it. So typically it readily can get in through the mucous membranes and that stuff, through your mechanical barriers. It's protected against the second line of defense, and typically it takes the third line of defense to do anything to it. And a lot of times these are normal colony or colonial inhabitants of your body that don't do anything. But typically when things get weakened or you get sick with something else, that's when these things cause problems. And so we'll talk about that as well. Okay, some other things that strep pyogenes can produce includes the streptolysins, which can lyse the blood, and again can cause cell and tissue injury if it gets into the bloodstream. You get this erythrogenic toxogen, which is a pyrogenic, causes fever. So a lot of times associated with strep infections are rashes and fevers. Okay, and so if you have a sore throat that has a high fever and a rash, it's probably strep. Okay, if you have a sore throat that doesn't have those things, it's either viral or something else that's causing the sore throat. So that's typically how we can diagnose strep pretty easily. If you have a rash, typically on the face, or you have a high fever along with a sore throat, that typically is strep. Now, not always is it strep, but it can be in certain cases. Superantigens as well. One of those things that can cause the superantigens, again, those are those toxins that get released and stimulate the T cells to cause that overwhelming response. And strep is no different than staph and able to produce some of these things that can cause this overwhelming T cell response. Okay, some enzymes it produces includes streptokinase, which can digest fibrin clots, so it can digest the clots and break them up. Another one is hyaluronidase, which can break down connective tissue, so pretty nasty stuff. And then the DNase, which can hydrolyze DNA. So this is one of the bugs that actually can cause the facilitating necrotitis, or necrosis. And again, this is that flesh-eating disease in this case. This is one of the bacteria that can do it, because once it gets into the tissue, it can start eating it away. And so Staph aureus and strep pyogenes are two that can cause some of the serious complications with this flesh-eating bacteria or the disease that it causes. Okay. Now, who is at risk? Again, humans are the only reservoir, so we're the only ones that carry it. Again, it's spread through inapparent carriers. So some people carry it and don't get sick by it, but they can spread it to people that are not healthy and get sick from it. And so that's where it happens. Again, transmission can be through direct contact, droplets through sneezing or coughing, can be passed on food and on fomites. So areas where people have coughed and then touched, that's a great way to spread the disease. Again, the portal of entry is either on the skin or through the mouth or nose, and typically that's where we find it is in the back of the throat. Children seem to be pretty predominant. They're the ones that typically get the strep throat infections. It's kind of interesting as we get older, as adults, we tend to be more immune to the strep and just become carriers at that point. So it must be something where our immune systems develop enough resistance to the strep that it doesn't seem to bother us as adults. And so we don't see as many strep infections as adults. Doesn't mean you're not going to get it. So don't come writing me an email and saying, Dr. Jim, I got strep throat last year and I'm 31 or whatever. It can happen, but it's more likely as a kid. And again, sometimes with strep throat, these, if it's not treated with the proper antibiotics and that stuff, it can lead to progressive sequelae, which means it can go and affect other tissues of the body. So typically what we see with a lot of strep pyogenes with these sore throats is that it can lead to either heart damage or kidney damage and cause long-term effects if it's left untreated. And so we'll talk a little bit about that as well as we go along. Okay, so some of the skin infections that, again, that we can see with Streptococcus is one is impetigo. Now, you remember I talked about impetigo before with the staph infections, and that was the baby acne, and it wasn't so severe. In this case, if you look down at the bottom of the screen, that's a pretty nasty case. Now, typically what it does is it forms this crusty skin that tends to flake off, and this flaking skin is very contagious. Again, you see this associated with poor hygiene. So people that haven't had showers or washed their face or their skin in dirty conditions, living in crowded conditions, you tend to see this. You will see this a lot of times when people have mosquito bites, a lot of bites or flea bites, and they itch and scratch and they leave those open wounds. So you'll see that as well. Perfect spots for bacteria to get in and cause these infections. So you see this. And again, it can be highly contagious. So if you have any wounds and you're treating someone with that, you want to be very, very careful that it doesn't spread to you. Now, another one is the uroplasia. And uroplasia is a red rash that's associated. And like I said, a lot of times with strep, you see rashes associated. So when we talk about scarlet fever and some of these other fevers, you're going to have a rash and a fever associated with the disease. And one of the rashes is actually caused by a skin infection that the bacteria gets under the layer of under the epidermis, causes inflammation, and leads to a red rash. That's actually due to a superficial infection of the skin that can get into deeper tissues. So it can cause more problems as time goes on, but it can be pretty nasty overall later on. So I just want you to be aware of that. So it can become systemic as well. Now, typically, again, another type of skin infection that can lead to deeper tissue infections is this necrotizing fasciitis. And again, this is caused by strep pyogenes, but it's not the only one that can cause it. And it's also known as the flesh-eating disease. And this enters in through breaks in the skin. So you get wounds on the skin, the bacteria gets in there, and again, the soft tissue then becomes damaged and destroyed by the bacteria. If you remember, there are lots of enzymes, lots of toxins that these guys produce that can break down the tissue. Okay, this tissue gets broken down very quickly and can cause severe damage to the tissue. It can lead to death if it's not treated very aggressively. And so one of the ways that they treat it is by getting rid of the diseased tissue. One of the ways to do that is through amputation. So a lot of times we see this either in the extremities, the arms, or the legs, or typically in a wound associated with that, and you have to remove the diseased tissue. Once you remove the tissue, a lot of times you can save the patient. So a lot of times it means removing an arm or a leg or doing one of those things. And by doing that, yeah, you lose the arm or the leg, but it also saves your life. And so again, where do we see this typically? We see this in people that have poor circulation associated with diabetics. We also see immune compromise because their immune systems, their second line or third line of defense isn't working so well. So they see this rapidly develop. And again, this can be very quick forming disease that can spread very quickly. So time is of the essence. So if you start to see tissue involvement, tissue being broken down, large abscesses, this is the time to go to the hospital and get this treated. Okay. Again, the best way to prevent this, proper wound care and having a healthy immune system. If you have those things, then you're at a very low risk of getting the infection. So again, does happen in that and can cause serious problems, And again, and this is something that can happen even to the best of us. So make sure you take care of your wounds, make sure you have proper cleaning and that stuff, and you keep your immune system up, and you shouldn't have a problem. Okay? All right. The thing that normally is caused by strep pyogenes is the strep throat. And this is what we see here. This is the inflamed area. So obviously you see the inflamed uvula and tonsils. Those things are red and pussy. Again, you may see some white spots associated with that. That's a very good sign for strep infection. Also, if the patient has a rash on the face and a fever, that's a really good sign of associating with strep infections. So typically with the strep, you're going to have a high fever and a rash associated because of some of the things, the pyrogenic toxin it releases that triggers the fever and the rash that goes along with it. So if you see those things, that's probably a good sign that you have a strep throat infection. Okay. Other things that can be caused, the systemic infections that are caused by strep pyogenes include scarlet fever. This is associated, again, getting strep throat, but then getting that red rash on the face or other parts of the body. And again, it's called scarlet because you get this really, really red rash. The erythrogenic toxin, again, high fever associated with it. If you see those signs, that's the time to take action. Get them to the doctor, get them to the hospital to make sure. This can also lead to septicemia, where the bacteria gets into the blood, could eventually lead to a pneumonia, and then also a toxic shock where it overwhelms the immune system, and then everything just crashes and shuts down. So that's some of the different types of systemic infections that are caused by this disease, all starting from the sore throat. And then other things that can be long-term complications that could occur from the sore throat is you get this sore throat, the bacteria leave that area and they can get into the blood and they can cause problems with other parts of the body. One part we see is with people that get rheumatic fever. Now, rheumatic fever, again, is another one, starts with a sore throat, leads to a rash and fever, so that some bacteria will get into the bloodstream and go to the heart. And so this can damage the valves in the heart and lead to a long-term effect or scarring effect of the valves. And so typically we see this later in life where this is affected, where you have damage to the valves and they don't open and close very well anymore. And that could be due to early on in life they had rheumatic fever that damaged the valves, and that was due to the strep infection. Another place we see this is also in the kidney. Now the strep can get into the blood, go down to the kidney and cause damage to the nephritis. Again, you see the increased blood pressure. Sometimes it can lead to heart failure. But eventually what can happen is that there's so much damage with the kidney over long term. The long-term effect is that it can lead to chronic infection and also lead to kidney damage and kidney transplant or kidney failure. So obviously these things can have long-term effects that even after the infection, enough damage could set in that later on in life it can lead to either valve replacement or kidney replacement if it leads to so much damage in these tissues. So just want you to be aware of that as well. Okay. So, concept checked. Which of the following is not a possible complication of strep throat? Is it rheumatic fever, scarlet fever, acute glomerulonephritis, or pneumonia? So, which one didn't I really talk about in those cases? Now, I did bring it up, but it isn't one directly caused by that. If you said pneumonia, you would be correct. We're going to be talking about the strep here that causes pneumonia here in a few minutes, but strep pyogenes is not really one that causes pneumonia very much. Typically, when we associate sore throats, we either see rheumatic, scarlet, or the acute glomerulonephritis associated with that. Okay? Pneumonia can happen, but not typically all the time. So if you said pneumonia, you got it right. All right, let's move on. All right, so the next type is the group B strep, the Streptococcus agalactae. And typically where we see this is that we see this in the vagina. And so typically where we see the infection is not so much the mother, but again, going to the baby. Now remember, the baby is sterile in that fluid, and once delivery happens, when you have the water break, that's the first exposure to bacteria. So if the baby sees this early on, passing through the vagina during the delivery, it can lead to certain complications. So a lot of times it can lead to neonatal pneumonia, sepsis, or meningitis. And so this is the leading cause of meningitis in babies. Okay, so when we say meningitis in babies, it's this agalactae or the esgalactae, and so that causes the problems. Now, it also can cause wound and skin infections and endocarditis in people that have weakened immune systems. So we also see that as well. But typically, where do we see this agalactae associated with is typically with pregnant women and then passing it on to the babies and leading to either sepsis or meningitis in the baby after delivery. Okay. Now, a couple other group streptococci include the group D, which includes the enterococcus. And again, these enterococcus are typically found in the intestine. That's why they're not called streptococcus anymore. They've been renamed for the enteric system. So they have the entero first part, but they are coxy bacteria. And again, they're typically found in the human large intestine, but they can pass to other parts of the body, causing urinary tract, wound, and skin infections, especially in people that are hospitalized. So you'll see that a lot of times where you'll get these enterococcal infections. And again, enterococcus is kind of nasty because it's resistant to a lot of things now. It's developed a lot of resistance, and it's because it's exposed to a lot of bacteria in the intestine that already have a resistance, and so they easily can pick up these resistance. And so we've seen a lot of resistant enterococcus throughout the course of in the last 10 to 15 years, especially the VRE, which is the vancomycin resistant enterococcus. So that can be a scary thing in those situations. Now, there are some other types of group C and G, which are found in animal flora. This can, again, spread to people and, again, can cause some different things like upper respiratory disease, pharyngitis, glomerulonephritis, and bacteremia in people. But typically, we find this in animals and it gets passed to people over a certain time. But typically, we don't worry so much about the C's and G's as we do with the A's and B's and D's. Okay. All right. And again, identification of these guys is based on getting the sample out. Cultivation diagnosis ensures proper treatment and prevent possible complications. So again, when you go to the doctor and you think you have strep throat, what they'll do is they'll take a swab in the back of the throat and they'll do a rapid strep test. The rapid strep test is shown down here. Again, a positive test will clump because the antibodies bind to the antigens. A negative strep test will not clump, and so that's how they determine it right away. And the results happen very quickly. It's kind of like the blood test. If you're testing for A or B type blood, this happens really quickly, so the doctor can say, aha, it came out positive. However, the warning for that is that, again, that there's sometimes a lot of false positives. So what the doctor will also do is streak that onto blood agar plates, and those blood agar plates will determine, is it a strep pyogenes or another type of strep or even a staph or maybe not even a bacteria at all. And so that's this test right here, and you can see it's testing with some other tests, and I'll explain those here in a minute. But what they look for is the lysine of the blood. If they see the lysine of the blood, they say, yeah, that's pretty definitive that it is strep pyogenes and you do have strep throat. Okay, and so that's what they look for. All right, so here the test again. This is just showing you on the blood agar plate. We are going to do the camp test in class, in the lab, and you're going to be able to tell. And again, positive versus negative. You also will do the bacitracin, which will tell you is it group A versus a different group. This other antibiotic, this SXT, which is also another antibiotic that we can test. And again, these just place it into these different groups and the different types of strep that are out there. And so this should be done as well as the rapid test. And so this is what the doctor also does. He streaks it onto a blood plate and determines, yes, you do have strep. So you may get the call 3 days later that says, oh, we determined that you don't have strep. Stop taking the antibiotics. You actually have something else. And that will tell you what you actually have due to the blood agar plate. Okay, so that's the difference between those. So that's how they do it. They do the rapid test and then they streak it on in blood just to make sure that you do have strep. And sometimes it's positive, sometimes it is negative, and then you'll stop the course of antibiotics. Okay, so that's what they look for. All right, so what is the treatment and prevention? So the nice thing about strep, a lot of these guys are not resistant, and so we can treat them with penicillin or penicillin derivatives like ampicillin, amoxicillin, or one of these other forms that go after the cell wall. Again, sometimes if people have had reoccurrent infections or a history of rheumatic fever or recurrent strep throat, they may go on a long-term penicillin prophylaxis, meaning they're taking it for a long time to get rid of it, to kind of get rid of all the strains of it that's they're harboring. They're probably a reoccurrent carrier or chronic carrier in these fashions. And then again, if you have enterococcal disease, which can lead to, again, skin infections, throat infections, other things, urinary tract, a lot of times they will do combined therapy because we find that these enterococcal species have a lot of resistance to them. And so again, that's the one typically found in the intestine. When it's in the intestine, it's fine. But when it gets out of the intestine, that's where it causes problems. And so that's where we see these issues that cause these different issues in people. Okay, and so that would be a combined therapy. Now, another group that we associate, so this is for you dental hygienists out there, so I didn't forget you either, is that obviously we have a large group of strep that grows in our mouth, and this includes the mutans, the oralis, the salvarius, the sanguis, the malariae, and the mitis. And so these are a very large combination of different type of strep. Some of you guys may have noticed that you had strep when you did your blood, or not your blood auger, but when you did your gram staining on your slides, and you saw, oh, I got strep there. You had chains of these little coxy bacteria. And I told you, well, you might have strep, but you may be a carrier, or you may just have it in your mouth. And strep is a very common inhabitant of the mouth, and it's just a different form of strep than the one that causes strep throat. So that's what you have to think about. Yeah, you may have strep, but it's probably not the one that causes strep throat. They're most numerous, widespread residents of the mouth, oral cavity, teeth, nasopharynx, genital tract, and skin. Again, they tend not to be invasive, so we don't worry so much of them causing disease. Where we do worry about them is if people have bloody gums, missing teeth, have dental extractions, surgeries, or other things, because those bacteria that are on your teeth can get into the bloodstream and then cause problems. And so that's where we worry about these. So you guys that are going in dental hygiene, this is what you have to tell your patients, is they have to be careful. If they have bloody gums, they can get strep infections that go to the heart. And so that's why you want to have good, healthy gums, not bleeding gums that can be a direct highway to the heart. Okay. And again, what these guys can do if they get into the bloodstream is cause bacteremia, meaning bacteria in the blood. They can lead to meningitis, abdominal infections, and tooth abscesses. So again, people sometimes will get cavities, not take care of it. These bacteria work underneath the teeth and cause abscesses that grow. Can be very, very painful. I've talked to people that have had them. I've had one in the past. Very painful. You feel like you just want to, punch your jaw or whatever, or pull your tooth out right then and there. And again, they can be pretty nasty infections. And so again, causing lots of problems. Again, the most serious infection is the subacute endocarditis. And again, what happens when you have these situations where you do have blood and blood vein, or your veins and arteries exposed and bleeding gums, is these bacteria can get in and go right to the heart. And what they do is they form biofilms on the heart, destroying the tissue of the heart and the valves that are associated with it. So you have issues there, and they can be at people with higher risks that have pre-existing heart disease. And so those that have already had heart attacks or other problems with their heart, maybe an enlarged heart or other things, high blood pressure, can have more problems or more complications. And again, when they get to the heart, they start forming biofilms on there and causing problems. So that can be the problem there. Okay, the mutan produces slime layers that adhere to the teeth, and so that's what you feel, the slimy things. That's probably the strep mutans along with other bacteria that grow on there. And again, without brushing your teeth, without taking care of your teeth, you guys in dental hygiene know, get dental caries. You got those problems, that's where you want to take care of your teeth. And again, getting them cleaned every 6 months so you don't develop problems like that. And if you do have dental caries and other things that you left untreated, that can lead to tooth loss, other problems like abscesses and that, and can cause more problems if they get into the bloodstream and go to the heart. Now, people that are going in for dental work, a lot of times if they've had heart conditions before, the dentist will recommend before they have treatment that they go on an antibiotic to prevent any of these guys actually going to the heart and causing problems or complications evolved with their heart. And so a lot of times, I know my dad is one of those that he has to take an antibiotic before he gets any work done, getting crowns, teeth cleaning, anything else. They want to be very careful in that stuff, that he actually has to go on an antibiotic before he gets his teeth worked on, because again, that can cause problems. And there's people out there that are like that, and it's typically routine and that stuff. They just don't want to cause any more complications than are already there. Okay, so that's why they do that. All right. Now, the last group of strep that we're going to talk about are the ones that cause pneumonia. And so we call this Streptococcus pneumoniae, and it causes about 60% or 60 to 70% of all bacterial pneumonias. So this is the one that we worry about the most. Now, you may have seen the commercials for it where those people are just doing the one, eating one broccoli or doing one sit-up or whatever, and they say, get this shot. This is what they're treating for. So this is the pneumococcus, this is the streptococcus that gets in there. Typically, we see it arranged in pairs. They call it, or short chains, they call this the pneumococcus. Okay, requires blood or chocolate agar and about 5 to 10% CO2. Now, what's interesting is these guys die in high oxygen. And so you'd think, well, why do they infect the lungs? Don't you think there's a lot of oxygen in the lungs? Well, typically where these guys set up is when the lungs are being compromised. So typically you have an infection already there, like the flu, that is already lowering the percent of oxygen that gets in there. These guys can then flourish in there. They start producing more and more fluid in the lungs because of the infection, and then there's less and less oxygen. These guys can thrive. And so it's kind of a catch-22. You start producing more and more of these guys in the lungs, less oxygen gets in the lungs. These guys flourish, cause more fluid buildup, less oxygen gets in there, and eventually the person will die from pneumonia because they basically drowned in all that fluid that forms in their lungs due to the low oxygen concentration. Okay, now all pathogenic strains have large capsules, which is a major variance factor. They also produce this SSS, or specific soluble substance. And again, there's 90 different subtypes of strep pneumoniae. So they're all strep pneumoniae, but they're the subtypes based on their capsule that they have on there. And so certain ones cause different things. And where we see these two diseases primarily with pneumonia, but it also causes ear infections in kids. And so a lot of times we see this guy in the back of the throat, and these are the ones that cause the chronic ear infections in kids. And I'll explain why that happens here in just a minute. Why do kids get it and not so much adults? Okay. So again, the epidemiology of this, about 5 to 50% of all people actually carry this. And so a lot of times this is due to self-inoculation. So you actually have the disease, or you have the bacteria in the back of your throat, and when you get the infection like a influenza, that influenza is there, these guys will then trickle down into the lungs and then cause the pneumonia after the fact. So if you were one that gets chronic pneumonia every year or every other year with the flu, you're probably a carrier of this strep pneumonia, and so it's causing this disease over and over again. Now, what's interesting about it is that it's very delicate, meaning that it can't be taken out of its environment. So if it's hiding in you, it's not going to leave you very well, because it is one of those things that it is very delicate. Now, again, it can be passed from person to person. When you cough, you sneeze, and that stuff, so it does can pass, but typically it's an endogenous infection. People are carrying it, and those that are carrying it will be the ones, or very close carriers type of thing, close to the kids or the older people. Now, again, the young, the elderly, the immune compromised, and those living with other lung diseases or viral infections are most susceptible. So again, where do we see it most is people that have the flu. So the secondary infection they get is pneumonia. And again, living in close quarters are also predisposed to pneumonia. So a lot of times nursing homes, if someone gets it, they're really worried. They'll put that person in isolation because they're worried about the rest of the residents of that nursing home getting the pneumonia. So it can be highly contagious as well. Pneumonia occurs when the cells are aspirated into the lungs. So again, you cough them down or swallow them down into the lungs. Okay. The pneumonia multiply and induce an overwhelming inflammatory response, which leads to fluid buildup, less oxygen, more bacteria growing, gains and then causes more problems in the lungs. That fluid buildup, fluid retention lowers the amount of oxygen that gets in there, makes it really, really difficult to breathe. And again, people die from basically drowning on the fluid that's produced in their lungs, okay, because they don't get enough oxygen to the rest of their body. Now, it can also gain access to the middle ear the way of the eustachian tube. And you know, our eustachian tubes are right about here in our neck. And so what they do is that, again, the bacteria lives in the back of our throat, and they can work their way up the eustachian tube and cause ear infections. And I'll show you a diagram of that in just a minute. Okay. So when we're talking about bacterial pneumonia, typically these guys are found in the back of the throat. Now, we normally have good cilia that work really well and keep things out, but when those get damaged, especially like with flu or other lung infections, sometimes smoking or emphysema can cause problems like that, where these bacteria can work their way down. So they work their way down, and once they're down in this area, they start producing an immune response. That immune response releases fluid due to the pus and other formations that are formed down there through the neutrophils. That fluid fills up the lungs, and essentially these people are drowning from the inside out. So the fluid produces, and you can't breathe very well. You're not getting enough oxygen to the rest of your body. And so essentially you're suffocating from the fluid in your lungs, and that's what happens in pneumonia, typically associated with other lung infections. Okay. The other thing that this can cause is ear infections. And again, we see this a lot of times in little kids. And so think about where this bacteria is. It's back in the throat. It can work its way up from the upper respiratory secretions, get into the eustachian tube, and work into the back of the eardrum. Now, the back of the eardrum, this is where the pain comes from because this fluid builds up and pushes against the eardrum. That pressure against the eardrum is what's very painful for kids, and that's what it is. You can't hear very well because the fluid buildup, the ears don't work very well. You have the pain and pressure against the eardrum, which is pushing past it, and so it can be very painful, especially for little kids. Now, why are little kids more susceptible to this than adults? Think about the position of the eustachian tube. In little kids, your head is not as big, okay, and your throat is much closer, and so the eustachian tube is more on a parallel line from the throat to the ear, and so the bacteria can easily get up that eustachian tube. As an adult, our eustachian tube elongates and gets more vertical, so it's much more difficult for the bacteria to travel up. Now, that doesn't mean an adult can't get an ear infection. I've had an ear infection as an adult, and so, but it doesn't happen as often as it does in kids. When you get a cold or whatever, a lot of times when kids get a cold, they'll get an ear infection, and that's because the fluid moves its way up the eustachian tube because it's more parallel. In an adult, we have more vertical eustachian tubes, so it doesn't tend to go up there as much, and so you tend not to get ear infections as much as a child. Now, one of the ways that we can actually help with ear infections is actually put tubes in the ear. And so this shows you a picture where a tube has been inserted in the eardrum, and what that does is it alleviates the pressure of the infection. It also helps drain the infection. So if you do get a lot of respiratory secretions that go up the eustachian tube, they can drain out of the ear. And so when the child lays on the side or whatever that hurts, the fluid will come out of the ear, and then the eardrum will lose that pressure, and then things will get better. As the child ages, that eardrum will seal back up and the tube will fall out, and everything will be fine. Hearing's normal, everything is fine. Now, where hearing can be damaged is obviously long-term or chronic infections can damage the eardrum. It can also affect the hairs, the little sensing hairs on the outside that can listen to sound, and so that obviously leads to the infections. So that's why tubes are really a possible choice for children, because again, if you get chronic ear infections in kids, a lot of times they'll get tubes to help relieve the pressure and also help drainage of the inner ear. And again, as we get older, our eustachian tubes become more vertical, and so we don't have as many ear infections as we get older as we do as young kids. And so again, you see that very often associated with colds and flus early on. Okay. All right. So what is the cultivation and diagnosis of this? And so obviously a gram stain of the exudate, so the presumptive identification. So doing the gram stain on it, looking for the diplococci or the pneumococci. A Quellung test can be done, or a capsular swelling test, and these are both antibody tests that can look to see if it reacts to the different types. Again, we can look for eta or alpha hemolysis. So again, partial clearing on a blood plate, so you can streak it on a blood plate. You can also look for the optogen sensitivity, so it's sensitive to that antibiotic. Look at bile solubility and inulin fermentation, so it can also break down inulin in this case as well. So these are all different tests that can help diagnose it, but typically the gram stain, knowing some of the signs and symptoms, can tell you that yes, you have strep pneumoniae. Okay. Now there is treatment with penicillin, so again, it does work with penicillin or derivatives of that. We are seeing increased drug resistance, especially in older people that have been around a while, so they see different bacteria and that stuff. But there are vaccines available, and so again, there's one for older adults recommended for people over the age of 50 to get that, and that's that one, do this one thing and save your life. And so this is the vaccine that you get, and again, we see it typically in older adults. Their immune systems are weakened, flu does havoc on their lungs, and then the secondary infection sets in. And then there is a vaccine also for young children that again does a pretty good job for very young kids, and then eventually as we get older we get a better immune response to it and that stuff, and then as we age again we have to get vaccinated for it again. So that's the two vaccines you may see. Okay, so there's a vaccine for strep pyogenes, or not strep pyogenes but strep pneumoniae, again for the high risk individuals in these situations. Okay, so Streptococcus pneumoniae, bacterial pneumonia, is highly contagious. Is that true or false? If you said true, you'd be correct, because again, we worry about this especially in certain populations. If you have populations that are high risk, we worry about these things spreading. And so if someone has pneumonia, we will put them in isolation to keep them away from the rest of the high risk individuals. And so if you did say true, it is. It is one that is, again, typically where their own flora causes the problem, gets in the wrong spot and causes it, but you can spread it from one person to another, especially in people that are high risk. Okay, so it does happen. So that would be true in the high risk individuals. Okay. So the last group we're going to focus in on today is a little bit different than the other two we talked about. The other two were gram-positive coxy. These are all gram-negative coxy, the Neisseria. Neisseria causes two main diseases that we worry about. These are residents of the mucous membranes of warm-blooded animals and includes Neisseria, Moraxella, and this Brahmala, I think it is. And again, the two main pathogens we worry about is the gonorrhoeae, which causes gonorrhea, and meningitidis, which causes most of the bacterial meningitis. So these are the two that we worry about the most. Again, the biggest difference between these guys and the other two is that these are gram negative. So they're going to stain red or pink on the gram stain. Okay, so what do these guys look like? Well, again, they're diplococci, a lot like the strep pneumoniae. Okay, they do not develop flagella or spores. They do have capsules, and you can kind of see the capsule around the bacteria here, and that they do have pili, which allows them to exchange genetic information. They are strict parasites, so they do not survive long on outside the host. So when people say you can get gonorrhea from a toilet seat, don't believe them, because these do not last very long on there. I guess it's possible if it was right after someone and they had a very nasty infection, it was oozing all over, but I find that highly unlikely that that would occur. Okay, it's either aerobic or microaerophilic, meaning that it needs oxygen to survive, and it does have catalase and cytochrome oxidase to deal with the oxygen. And again, the pathogenic species require very enriched media in order to grow it up in the lab. Okay. Now, gonorrhea is the one that causes gonorrhea. It is an STD. Again, it's one of the top five STDs in the country, anywhere from 100,000 to 300,000 cases a year. You guys saw this when we did the MMWR in the lab, and you guys saw that this was one of the highly reported diseases. Two of the virulence factors are the fimbriae that it has allows for attachment to the mucous membranes, and then this IgA protease, which actually allows for the breakdown of the antibody that's found in the mucous membrane. So you remember the secretory IgA that mucous membranes produce? Well, this guy can destroy those. So again, that's how it lives on these surfaces. Now, what does it cause? Well, it causes gonorrhea, and again, the epidemiology is it's strictly a human pathogen. So you're not going to get it from any other animals. You're only going to get it through passage through fluids that of an infected person, okay, typically through sexual contact. And again, it's a top 5 reported STD in the United States, has an infectious dose of 100 bacteria to 1,000, so it doesn't take much to get you infected, and it doesn't survive longer than 1 to 2 hours on fomites. So again, very unlikely you're going to get it from a surface from someone that has it. And again, I would seem that it would be very unlikely, extremely unlikely that you get it from a fomite. You're more than likely going to get it through sexual contact from one person to the other. Now, if you look at the trend over the last 30 to 40 years, you can see that gonorrhea and syphilis were quite high during the 70s. Again, this is when there was a lot of free love attitude and a lot of promiscuous attitude that went on during the 70s. As the AIDS scare came along and people had started using condoms and practicing safer sex, we saw the number of gonorrhea cases go down tremendously. However, you still can see that number is anywhere from 100 to 200,000 cases a year. So that's a lot of cases that still happen every year. And what we do see is that these are reoccurring infections. So the same people that get the infection once get treated and then get it again, again, and again. So it's one of these common things that we see typically in a lot of different populations. Okay. Now, in males, it causes urethritis, which is the inflammation of the urethra, can lead to a yellow discharge, can cause scarring and infertility if it does get into the vas deferens and causes scarring. And so what that is you get scars in the vas deferens, which leads to the inability of the sperm to make it up the vas deferens and out the urethra. Again, most males, so 90% of males, have some kind of symptoms with it. Now, there are 10% of males that are asymptomatic, and so if you're having issues with having children, this might be one of the reasons why, that you had scarring due to an STD that wasn't treated or was treated but caused scarring in the tissue and you didn't know it, and now you're having fertility problems because the sperm isn't able to make it all the way out the urethra, okay, during ejaculation. It's one of the things that can happen. Now, in females, you can get a number of diseases, including vaginitis and urethritis. Okay, can also cause a mixed aerobic abdominal infection and can cause sterility and ectopic pregnancies, which means that the embryo binds on in the fallopian tube and starts to grow there. Now, this will not be a viable pregnancy. A lot of times, what happens is that this will cause a rupture of the fallopian tube and bleeding, and so women will feel this pain. They'll say, "Hey, I'm pregnant." Yay, they'll have a positive pregnancy test and not know until they either see some bleeding or spotting that occurs. And when that bleeding occurs, that's rupturing of the fallopian tube, and they'll feel this pain in their abdomen right after finding out that they're pregnant. And again, that's due to an ectopic pregnancy, and that can be due to the scar tissue due to the STD and that. Now, the problem is that in females, 50% of females are asymptomatic, meaning that they don't show any signs or symptoms of when they get the infection. So this means that they can pass the disease on to other people without even knowing that they have it themselves. And so this is why I say the numbers of like 100 to 200,000 is probably not enough. It's probably more than that because a lot of people don't report it because they have the disease and they don't even know it. So in women, you have to be extremely careful because you may not show any signs or symptoms. About 50%, so 5 out of 10 do not show any signs or symptoms that they have this disease. So that can be scary. Okay, you may have the disease and not even know it. All right. It can also lead to complications if you do get pregnant and you have a baby. Now, if you have gonorrhea and you don't know you have it, you can pass it to the child and they can get infected through delivery. Okay, they get the disease in their eyes, can cause blindness and eye inflammation in babies. And so, one of the reasons why babies get eye drops after a natural delivery, or they probably even do it even in a cesarean, is that they want to make sure that any bacteria and bacteria pathogens that they may have been exposed to coming out of the birth canal are eliminated out of the eyes so that they don't have to worry about blindness. So obviously this is a very severe case that was caused by a delivery where mom probably didn't know that she had an STD and now the baby has it and probably will cause blindness in this situation. Okay. Now, how do we control it? Obviously, the diagnostic test is doing scrapings of either the urethra, so it's not a pleasant way to diagnose it. So it'd be taking, for men, taking a Q-tip or a swab and going up the urethra. So if you can visualize that, doesn't sound very pleasant, and scraping some of the cells out of the urethra and then plating them on a slide and seeing if you have the infection. Same thing for women, going around the vagina or urethra and looking in there. And again, looking from the exudate, vaginal, cervical, or eye exudate from secretions, and then doing presumptive identification. Most of them can be treated with penicillin or tetracycline. However, a lot of them now, 20 to 30% of these guys are now where we're finding are being resistant. So other drugs, and so that can be a really scary thing if we now have STDs where they're now highly resistant. Again, recurrent infections occur a lot of the time. It is a reportable disease. You guys know that. It's reported to the CDC. So anytime either a man or woman comes into the doctor's office and has gonorrhea, it gets reported to the CDC, and that is a notifiable disease. And again, we're seeing more resistance. So those people that keep coming back are the ones that are causing the resistance to occur. They get treated with the same antibiotics. Those bacteria develop resistance, and now we're finding more and more resistant strains. And so it's going to get to the point where these people are going to get it and they're going to have it the rest of their life because they're not going to be able to get rid of it with the antibiotics because there's going to be no antibiotics to treat it. So that's a scary proposition. Okay, so think about that. All right, so the other type of Neisseria we worry about is the meningitidis. And the meningitidis is the one that causes meningitis. And I would say it causes about 70% of all bacterial meningitis. Now, the virulence factors associated with this are the capsule, the adhesive fimbriae, the IgA protease, and the endotoxin. And again, there are about 12 different strains of the Neisseria meningitidis. And again, we describe them by the serotypes A, B, C, D, and so on. And the ABC are the ones that cause the most cases. And again, who's at risk for this disease? It's going to be you guys, the college age students that live in dorms. And so that's where you see this disease most propagated. Okay, it's a prevalent cause of meningitis, and I said and about 70% of all meningitis cases are probably due to Neisseria meningitidis. It can be either sporadic, where it happens to one person, or it can be an epidemic where you see many people infected with this, and that can be a scary thing, especially on a college campus. Again, humans are the reservoir, and it's carried in the nasopharynx, so in the nose and the throat, and about 3 to 30% of adult population actually carry this without any problems. We see higher numbers in institutional settings, and again, people that are living together in close quarters are most likely at risk because you have more of a population that has it, carries it, and sharing of water bottles and food items and utensils and things like that put people at high risk for these things because you have these non-apparent carriers. They pass it on to someone who's susceptible, and now they get the disease. Again, high-risk individuals are those that live in close quarters, children 6 months to 3 years, and then children and young adults anywhere from 10 to 20 years. I would say college-age students are probably the highest because, again, think of dormitories, army barracks, things where you're going to live in close quarters with a lot of different people that are just coming together for the first time. Again, the disease begins when the bacteria enter the bloodstream. They can cross the blood-brain barrier, inflame the meninges, and then they get into the cerebrospinal fluid and cause infection in the spine. So the two typical symptoms that you feel are severe headache and a severe neck ache or backache associated with the bacteria growing in the spinal fluid. So again, this is a very rapid onset type of disease. So if someone complains of a severe headache and a neck ache at the same time, you want to get that person to the hospital right away, because this is not something you want to play around with and say, oh, just sleep it off and see. Because if you go and let them sleep it off, they might not never ever wake up again. And so it can be a scary thing. So if you have a teenager or a college age student that is about that age and they're complaining of a really bad headache, and I'm talking about one of the worst headaches they ever had, and they also have either neck or backache associated with it, don't waste any time. Get them to the hospital because they probably have meningitis in this case. Okay, and so this can lead to other complications like hemorrhaging, shock, and it can lead to death. And like I said, death can occur within 18 hours of initial infection, so it can be a very fast infectious disease. Okay, the way that this bacteria is, again, it's found in the back of the nose or the throat. So again, self-inoculation can occur, but typically it's from passage from people that are carriers to people that don't get it. So on droplets and other things, it enters into the nose or the mouth. The bacteria then can cross into the brain, get into the blood, and they get into and cross the blood-brain barrier, get into the cerebrospinal fluid in this case, also get into the meninges and cross into the spine and travel down the spine. So you can get it into the neuro tissue in the middle and then also around the outside where the cerebrospinal fluid is. Now, one of the complications you see with that is you start to see hemorrhaging in different parts of the skin. So the blood vessels are actually breaking open and leaving blood underneath the skin, and that's the hemorrhaging part. You can get bleeding from the eyes sometimes, not typically, sometimes from the nose. But essentially, the really bad headache and the neck ache are the two telltale signs. Now, when the person does go into the hospital, the first thing they're going to do is a spinal tap. If they suspect meningitis, whether it is or isn't there, they will do a spinal tap as a precautionary method. Now, what they'll do is they'll look for it, especially if this fluid comes out cloudy. They know they have some type of infection going on that's affecting the brain and the spinal fluid, and probably would diagnose it as a bacterial meningitis. They will do a gram stain on it and then also take a test to make sure that it is Neisseria meningitidis. They can test for that, again, culture for differentiation. But as soon as they do the spinal test and it comes out positive, they are going to put you on antibiotics. Now, what's also interesting is those that have come in contact with it, whether you be the healthcare worker or a person that you've run into, or maybe a family member in the last 5 to 7 days, maybe 3 to 5 days, you will also be put on antibiotics because it is that contagious. So they worry about this, that it can spread from one person to another. So if you've come in contact with that person in the last 3 to 5, 7 days, you are also going to be put on antibiotics. So that's why they get the word out. So if you're on a college campus where there has been bacterial meningitis, they will say, hey, if you've been in contact with this person in the last 5 days, you also need to go to the clinic to go be put on antibiotics as well. And that's just a safe, prohibitive, or preventative medication for you guys to do that in order for that to happen. So it's just for your benefit as well. Okay. Again, it's treated with penicillin or cephalosporin or one of the bacteria cell wall types of things. Again, amoxicillin, ampicillin, one of those. Prophylactic treatment for family members, medical personnel, excuse me, children in close contact with the patient. Again, the last 3, 5, 7 days, they're going to put everyone on antibiotics to make sure that everyone's safe. And there is a vaccine out there, so I highly recommend if you have college age students or you are yourself as a college age student and you are living in close quarters with other people, sharing an apartment or dorms or other things like this, you would most likely want to get vaccinated for this. It's one simple shot, be vaccinated, and it's a good preventative measure against getting this disease. So I highly recommend it because we do see quite a large spread in college age students. So you guys are the ones at risk. So just be careful about that. Okay, so the last thing we're going to do is the concept check. So the common cause of meningitis in young adults is found in what genus? Streptococcus, Staphylococcus, Neisseria, or the Brahmaella? Which one is it? I like the Brahmaella or Brahmaella, whatever it is, but it is Neisseria. If you said Neisseria, you are correct. So you are paying attention. Good job. All right, so let's summarize these. So we talked about 3 main bacteria today. The Staphylococcus species is a gram-positive coccus, forms clusters, it's coagulase and catalase positive. So you're probably asking right now, Dr. Jim, there seemed to be a lot of information on this. What am I supposed to know? Really what I want you to know for this test is know some general characteristics about the bacteria. Know that it's gram-positive or gram-negative, know what the shape is, and know what some of the distinguishing or definitive tests are. So if I say this is a good test to know, like coagulase or catalase, make sure you know that for that. So what they do, okay? And then don't worry about the diseases. What I typically do is ask about where do they target. So like with staph, they tend to target skin infections. Strep is typically throat infections. Sometimes you get the heart or kidneys involved, and then or the lungs with the strep pneumoniae, and then Neisseria, either the genital urinary tract or with the meningitis, the brain type of thing. And so you guys are smart enough to figure that out, where they infect and things like this. And that's what I'm going to be asking. I'm not going to be asking these very specific questions about it, so don't worry about writing every little piece of information down. What I want you to get is just the general gist of what these guys are. Okay, so for the staph, know that they're gram positive. Know that they're formed in clusters. Okay, that they're coagulase positive for Staph aureus, and that they're catalase positive for all the staphs. So the way that we distinguish Staph aureus from the rest of them is the coagulase. Remember the clotting of the plasma. Okay, Staphylococcus produces a lot of enzymes and toxins. It can cause a lot of serious skin infections, can lead to some systemic diseases in the bone and tissues. Many of them are penicillin and ampicillin resistant. And again, we worry about the MRSA. MRSA is the methicillin resistant Staphylococcus aureus, so the MRSA. So again, these guys with the big cell walls and that stuff can cause problems. Now with the strep are again gram-positive coxy. Again, they're found in chains. They're catalase negative, so that's the big distinguishing between the staph. These are catalase negative. The other thing is what they look like. They look like chains, not clusters. Okay, they're categorized by the types of cell wall antigens, and again, I'm not going to ask you if this is an A, B, C, or D group type or whatever. But again, we talked about some nasty diseases. One of them being the strep throat, which causes necrotizing fasciitis, the flesh-eating disease, along with scarlet rheumatic fevers and strep throat. That's all strep pyogenes. You can talk about the dental caries and endocarditis with the Verdun strep. These are the different ones, the mutans and all these other guys, but just refer to them as the Verdun strep. Pneumonia and ear infections with the strep pneumoniae. And again, a lot of these guys can be treated with antibiotics because we don't have a lot of resistance, as well as the strep pneumoniae has vaccines for it. So again, ways to protect ourselves. Okay, the last group we looked at was Neisseria. What separates these guys out from the rest of them? These guys are the gram-negative coxy bacteria. And again, typically found as Diplococcus, found in mucous membranes of animals, and they're catalase positive, so they bubble with hydrogen peroxide. The 2 groups that I want you to know are the Gonorrhea and the Meningitidis. The Gonorrhea causes gonorrhea, which is a top 5 STD. Again, most males show symptoms, about half the females show symptoms. So again, that's where the discouraging factor of this is about. So a lot of women have this disease and don't know they do because they don't show any symptoms. Again, it is treatable, but we are seeing more resistance in some of these strains. And again, this tends to be a reoccurring infection where we see the same people get it over and over and over again. Okay, the meningitidis is the meningococcus, again, diplococcus that we tend to see. And again, it's one of the leading causes of bacterial meningitis. I would say about 60 to 70% of all meningitis is caused by this guy, the Neisseria meningitis. And again, it can be treated. However, quick response is the idea. If you're complaining of a severe headache and neck ache, go to the hospital because this is something you want to get checked out. And I'm talking about one of your worst headaches, not just a little sinus headache or something that you feel like the world could end. I'm talking about something that's going to be a lot of pressure. You feel like your brain's going to explode or something like that, and you got a neck ache. You know, you're better safe than sorry. And again, where do we see this most? A lot of time in college age students, most of you guys that I'm talking to. So there are vaccines available. I highly recommend getting vaccinated for it and being protected. That way, even if someone is exposed, someone has it, and you come in contact with them, you should be okay because you've been vaccinated for that disease. Okay? So again, I thank you for watching today. If you have any questions, please ask, send me an email, send me, a question on YouTube or whatever, or in the comments section. If you have any issues, please let me know with anything, and I'd be happy. Stop me in the lab or in my office hours and ask me there. And again, if you have any questions, please ask because I'm always there. If you want to pick my brain a little bit about these things, if you have some relevant questions about these things, I'm always glad to listen to them and see if I can answer them for you. And if I can't answer them, I'll find out the answer for you and that stuff. Okay, we've come to the end. I thank you for watching today. Hopefully you learned something about staph, strep, and Neisseria, and that you're ready to go on and tackle the other ones in chapter 18, okay, or chapter 19. So for next time, I'll see you then. Thanks.